Hello, and welcome to Evaluating and Viewing the Radiograph. This is RAD 1126, lecture number 4. Today's objectives. We have a good amount of things to go over. We'll be looking at the position and other factors, part position, alignment, what these terms mean, the presence of radiographic identification, what does it mean to have evidence of radiation protection. We'll talk about artifacts, film and part identification, the use of radiographic markers, viewing the radiograph, things like illuminators, spotlights, and the influence of ambient light. When it comes to film critique, the process of evaluating the quality of a radiographic image. A film will be taken. When it comes out of a processor, or if it shows up on a screen, in any manner, the image will be based either acceptable or unacceptable, and that determination will be based on the criteria that we will be discussing. Among other things, positioning is one very important aspect of the criteria. In fact, it may be the most important aspect. If a part is mispositioned or not positioned correctly, it will result in a repeat examination. This will provide more radiation to the patient, and it's more time consuming for both you as the technologist and an inconvenience to the patient. So film critique in and of itself combines multiple ways to view an image, and almost imagine a checklist where you have to look at not only the positioning, but the other items that we'll talk about, such as alignment, collimation, patient identification, and marker placement. Although we will discuss all of these separately, all of them are happening basically simultaneously when you make that exposure. Let's begin. When it comes to positioning and IDing the patient, even if everything is perfect, your positioning, your alignment, your collimation, the central ray, you even shielded the patient. If the patient information, the name, the date, medical record number, accession, and other items are incorrect, then that can be devastating to the patient. In one worst case scenario, patient's information are mixed up, someone goes to the operating room and they're not the right patient, and you can imagine the consequences. The following characteristics of the image need to be evaluated. The position of the body part. Again, if the part is rotated or elongated from unnecessary angle, or simply cut off, all of these are reasons to repeat an examination. The image must be aligned. Central ray, center to the center of the image receptor, and then the central ray going to the appropriate anatomical area of the part in question. For instance, if we're radiographing a hand, first the central ray should be centered to the center of either a CR cassette, a film screen cassette, or detanted and centered to a flat panel detector. After that first step, you must then center the central ray to the base of the metacarpal of the hand. That would give you proper centering and alignment. Keeping it simple, we're basically talking about getting the part in the middle of the image receptor. What does evidence of radiation protection mean? Well, we're talking about two different things, really. One example would be making sure that there are 4 clearly defined borders of collimation. If we only count 2, then we're not sure exactly what happened to the radiation on the other 2 sides. If we don't see any collimation, and for example you were doing a hand x-ray, which could basically be done on an 8 by 10 perimeter image, you might as well have had the collimators completely open. If there's no border, there's no telling where the radiation would be. In fact, there's no evidence. Evidence of radiation protection can also take the form of indicating on the radiograph that a lead apron or shielding was utilized on a patient. Shielding is often used to cover the gonadal area of a patient and or the thyroid. Generally speaking, if you can capture a part of the shielding on your finished radiograph, then it will be evident, in other words, there will be evidence that radiation protection measures, in this case shielding, was utilized on a patient. Another type of evidence of radiation protection deals with the EI, or exposure index analysis. We haven't yet spoken about this, but this is a digital number, so this applies to both CR and DR types of radiographs, where an indicator will basically tell you if too much radiation or too little radiation exposed the part. This is a numerical figure that will show up within the metadata based on every image that is taken. Again, correct and complete ID. Is it enough just to have a patient's name and date? Of course not. There are many patients that have the same name. What else would we need? Birth date. Well, that's getting closer to all the things we need, but is it possible to have 2 patients with the same name and the same birth date? There's only 365 days in a year. So it's important to have more than just those basics that you might have thought about. It's important to have a patient medical record number, which is usually an 8 to 10 digit number, which will uniquely identify a patient, similar to what we would have in a Social Security number. Also, most hospitals use an accession number, which is a specific number that is tied to the actual examination being done on that day. In other words, a patient's medical record, when pulled up on a computer system, would bring up many, many different accession numbers that are again linked to individual exams that a patient may have had during the history of their exams at a given institution. The presence and placement of either right or left markers. This has been discussed before. It's not enough, even though we are in a digital world, to pop a marker on and annotate an image in a digital fashion. A right and left marker must be present during each examination, each view, and on every exposure taken. Not just any marker, the proper marker. So please be careful. If it's a right hand, it's a right marker. If you're doing an abdominal view, there's no left abdomen or right. We mark the left side or the right side. And the absence of artifacts and foreign objects. It's very important to delicately handle the film, as we've done in several labs. And it's important when an image comes out to not only look for the basic things like positioning, alignment, collimation, markers, but to take a closer look and see if there's an artifact. An artifact is really anything that is not part of the original image. There are many different types of artifacts, and part of this discussion that we will be having today will be giving you examples of artifacts, as well as any foreign objects that could appear. So, position of the body part. We've talked about this in our introduction. This is probably the most important aspect of image quality and the film critique process. We are looking for the correctness of the anatomical position, making sure that the central ray angle is correct. If a tube is turned or angled, either sapphically towards the head or caudally towards the feet, it will cause an elongation or stretching out of the part. There are certain views for certain positions that we do this on purpose, and in that case, having an angle on the tube is okay. We are also looking for what we call rotation. In most of the views that you're learning in positioning, it's important that certain structures superimpose other structures. If a film is rotated because you have, let's say, medially rotated more or less than necessary, it will cause structures to overlap in ways that were not expected. This can cause a misdiagnosis, and with severe rotation, usually will result in a repeat of the examination. Alignment of the tube and the film, or in a more modern department, the CR, or the flat panel detector. Positioning is nice. It's nice to have accurate positioning. In fact, it's required. Centering and alignment is also a requirement. We need to get that image in the middle. If you're off center, like this lateral lumbar spine that you see here on your left, while you may have positioned perfectly, all of the spinous processes posterior there are cut out. This is not good. Have some collimation, that's good. But if your alignment is off and you cut the part, it's a repeat. Again, repeats are just simply unnecessary exposure, basically doubling the exposure for that patient, for that view. Misalignment can occur if you are not transversely detanted to the image receptor. Evidence of radiation protection. Well, as mentioned in the introduction, we have two different types of radiation protection evidence. One regards collimation. If you look at this spot film of L5S1, we see that there are clearly defined borders of collimation. This is evidence. Anyone that looks at this knows where the radiation stopped. It's clearly visible. On the right side, this white area here is evidence on this lateral chest x-ray that gonadal shielding was seen. There are some other reasons. Additionally, another rationale for four sides of collimation has to do with CR and DR imaging. We've yet to learn a lot about CR and DR, but you can imagine that there are mathematical algorithms that are utilized in the reconstruction process to make images of diagnostic quality by adjusting contrast and/or density. In some cases, these computers utilize the borders of collimation with which to factor in when calculating the algorithm utilized in creating a proper density and/or contrast. If the borders are obscured, as you see here, or if you do not have any collimation, or a third aspect is even a lead apron, could possibly throw off the algorithm, in which case there is an argument that could be made for not showing the evidence of shielding. Correct and complete ID. You could argue that aside from positioning, this is the most important aspect of any radiograph. There must be at least one unique identifier, and it's not a social security number. It's the medical record number, often abbreviated as MR. A date is necessary. Generally, the type of case is identified, and that's often done with the previously mentioned accession number. Again, a patient who has many radiographs in the same institution will have one medical record number, but can potentially have dozens of accession numbers. And usually the patient's name is included as well. But in the list of what is important, a first and last name is generally not the most important piece of data within the data set. And speaking of data set, there are many data points or fields of information that are now associated with digital images. This is all part of what's known as DICOM, D-I-C-O-M, data. Sometimes this information is not so easy to find. When an image is pulled up off of a computer workstation, you'll often see the MR and accession number, the date, patient's name. But there are many other attributes such as exposure index and other values that are attributed to the image but are not often easy to find. We'll talk more about this in another class. Here's an example of some of the data that you might find in the DICOM header. Things like study date make sense, but there are series and acquisition group lengths and universal identification data, the series number. The list goes on and on. This is a lot longer list than simple name, medical record, accession number. Right and left markers. We spoke about this earlier, but it's important to really make sure that you understand the consequences that a simple mistake can make. Again, a marker defined by law must be present during the actual exposure. It means they must be on the image plate, on the image receptor. Somehow it must end up on your ultimate image. Here we're indicating that this is the left hip. I sincerely hope this is the left hip. This marker could possibly be wrong. So really, we're not talking about just marking. We're talking about marking correctly. A very simple and easy mistake can have drastic consequences. Additionally, this marker must show up within the border of collimation. A marker that was placed, in this example, in a corner of the image, being collimated out would just not show up. An excuse from a student, or technologist for that matter, that I marked the image doesn't really hold weight if that marker is not actually visualized in the resulting image. The absence of artifacts. Artifacts, as we have described in another class, are anything that shows up on an image that is unwanted. Images or marks which should not appear in a radiograph. And artifacts can come in many, many different varieties.